Ladies and gentlemen, boys and girls, welcome to the 42nd episode of the Indian Journal of Anesthesia podcast. In this episode, we have something special as a discussion focused on malignant hyperthermia, a rare but potentially fatal condition that demands our attention as anesthesia professionals in India. I'm your host for today, Murali, and we are joined by distinguished experts who will help us navigate the complexities of malignant hyperthermia diagnosis, the management, and unique challenges that we face in our country. From clinical recognition to treatment strategies, when Dantroline is available and when it's not, we will explore some practical approaches that could save lives in our operating rooms. I am joined in this episode by Dr. Balavenkat Subramanian, the President of IJA National and the Secretary for the World Federation of Society of Anesthesiologists, Dr. Rakesh Garg, the Editor-in-Chief of Indian Journal of Anesthesia, Dr. Nandini Dave, the Senior Consultant and Head of the Department at SRCC Children's Hospital in Mumbai, and Dr. Shilpa Bhat, Assistant Professor in Anaesthesia Medical College in Bangalore. To start the discussion, I would like to welcome Dr. Balavenkat to the episode. Sir, welcome to the very special episode of the IJA podcast.
Thank you, Murali. It's a pleasure to be a part of this podcast.
So we are going to be discussing something, as I mentioned, very unique to the anesthesia specialty and something that none of us as anesthetists would like to face in our lifetime. How prepared are we in our Indian hospitals for an MH crisis, sir?
I think this is a very pertinent and very important question. It's been long thought that Indians were immune and never had malignant hyperthermia. So it was firmly believed that it was a disorder of the West until we realized that malignant hyperthermia is happened, and had been fatal with sporadic case reports from across the country. Unfortunately, as of today, we do not have a registry of malignant hyperthermia, so we cannot pinpoint incidence of that. But since it is believed, or it was believed, that it's not a disorder for this country, every hospital in this country, majority of them are not prepared to handle a malignant hyperthermia crisis. Of late, I understand that few institutions in this country have got a ready stock and store of Dantroline, but that would be a very, very small number of institutions having it. So I feel a lot of awareness has to be created in this nation, and we need to make this podcast reach every single anesthesiologist of this country to create that very much needed awareness in dealing with malignant hyperthermia.
The availability of Dantroline has been an issue when it comes to handling these cases. Can you just throw a little bit of light on why Dantroline availability is such a critical issue in India?
Yeah. So all of us know that the treatment once malignant hyperthermia is diagnosed is Dantroline sodium. And I'm very happy to share that I have had the opportunity to use Dantroline sodium and get back the child who was posted for a spine surgery within seconds of administering 2.5 milligram per kg of Dantroline sodium. It was a treat to watch the temperature coming back to normal, the carbon dioxide coming back to normal within minutes of administering Dantroline. So in literature, it's very clear the drug of choice in treating malignant hyperthermia is Dantroline, intravenous Dantroline sodium. Now, is it really available in India? Answer is no. Is it manufactured in India today? Answer is no. So what is the source of procuring Dantrolene in this country now? Dantrolene is primarily procured through import of this drug from either Europe or United States. There are two formulations that are available. One is Dantrium, which is 20 milligram vials that are currently commercially available. And there is one more, which is 250 milligrams. So there are two different formulations that are available. And current sources importing it from, as I said, either from Europe or United States. Now, what are the challenges in importing this drug? The challenges have been a prescription has to be given because it's a drug that is imported. A prescription has to be given by the hospital for a patient, and there are only few agents who procure it and give it to us, and they place an order, and they get it, and we need to get a clearance from the airport's authority, and then they pass it on to the respective hospitals. And when we do this, the current cost of it is the 20 milligram vial is costing approximately 22,000 Indian rupees. And if you need to treat an adult, so we need 2 milligram per kg body weight, that's about 150 milligram, that means 7 vials, 7 into 22,000 rupees is the cost. There is one more challenge in importing this. This Dantrium sodium, which is 20 milligram, is available in a box of 12. And when we want to procure it, they're giving the entire box rather than giving it in individual vials. So this is the other challenge, and which means it would cost 2.7 lakhs to import this box. So this has been a major limitation, but as an organization, the Indian Society of Anesthesiology is now moving in several fronts to address this issue. Number one is to see how to procure it on a large scale and distribute it across India. Number two, to make this drug to manufacture in this country itself, because raw materials are available in this country. We are in the process of making it manufactured in India itself. And one more reason why we don't get this drug is the shelf life. The shelf life is 2 years, and all the people who are importing the drug, they feel that if the usage is not there, if they stock it, it goes as a complete waste if the orders are not placed. So these have been the challenges. So number one, not available. Number two, it has to be imported. Number three, the cost. Number four is the short shelf life.
One of the questions that many viewers, listeners might have at this moment is, are there any alternatives to Dantrolene?
I think at this point of time, I would say that absolutely there is no alternative as an antidote for Dantrolene. However, as I mentioned this, best alternative is whenever either if there is a history of hyperthermia in the previous procedures or in musculoskeletal disorders, because majority of this disorder has been found to be associated with some form of musculoskeletal disorders. The best thing is to avoid triggering agents and probably considering every single patient as a potential candidate who can develop malignant hyperthermia, and avoid all the triggering drugs including suxamethonium and the inhalational anesthetic agent, and going in for complete total intravenous anesthesia. That's number one. Number two is the minute an end-tidal carbon dioxide started rising or there is tachycardia, we have to sensitize every single anesthetist that they have to think of the possibility of malignant hypothermia and immediately take off the triggering agent or the inhalational agent. I think this is the best thing that this podcast can share. I mean, when we share this podcast with everyone, they have to realize that malignant hypothermia is one of the causes of raised carbon dioxide level and tachycardia. So normally what happens when there is increased in heart rate and when the EtCO2 starts going up, they consider it as a light plane of anesthesia if they're not monitoring the bispectral index. And when they think it's a light plane of anesthesia, they try to deepen the patient by giving more of that inhalational agent, and that makes it much more difficult and the patient becomes much more sick. So in a nutshell, number one, consider every patient as a potential patient who can develop malignant hyperthermia, especially if they have musculoskeletal disorder. Number two, use agents like the total intravenous anesthesia and prevent using the inhalational agents and succinylcholine, which are the triggers. And number three, any rise in end-tidal carbon dioxide or tachycardia intraoperatively, to consider MH as a possibility and take off the offending agent immediately.
Thank you, sir. Thanks for highlighting the importance of malignant hyperthermia. In our country, the critical issue of dantrolene availability and how it can impact decision making, and also the main key factors what people have to look out for. I'll just shift the discussion a little bit to what happens in malignant hyperthermia, and I would request Dr. Shilpa to join the discussion now, who's had a personal experience having handled a patient. Dr. Shilpa, welcome to the episode. Now,
Thank you, sir.
what I would like you to share with our viewers is malignant hyperthermia in terms of a condition. What does it mean when it comes to the healthcare professionals as anesthetists in this case and the general public? Now, how does it differ in the way we understand it? Is there anything different there?
Okay. So to address this question when it comes to healthcare professionals, so for us, it's a very rare pharmacogenetic disorder. So mainly seen in patients or a population which is genetically susceptible to malignant hyperthermia when they are exposed to certain amount of trigger agents, which could be halogenated volatile anesthetics or succinylcholine, as we already know. So basically, they are having a hypermetabolic response. This is basically because of a dysregulation of calcium hemostasis. So the literature so far mostly connects malignant hyperthermia to the RYR1 gene mutation. So most of the malignant hyperthermia patients are susceptible to a mutation with RYR1 gene. But recently, we have also seen mutations with other genes like CAC-NA1S gene and STAC3 gene. So basically, all the problem that is like genetically or in a molecular level that's arising is because of the problem with the excitation contraction coupling, which is occurring in the sarcoplasmic reticulum of the skeletal muscle. So what are the like important factors here? Are the genes contributing to this? Like ryanodin receptors play a very important role to release the calcium. So this is coded by the gene that is RYR1 gene. And at the same time, we need dihydropyridine receptors, which are coded by the CAC-NA1S genes. So diagnosing mutation in these genes could probably help us to know which patients are susceptible to have an event of malignant hyperthermia, which could present with increased uncontrolled release of calcium, which could lead with hyperthermia and sustained contraction of the muscle, leading to muscle rigidity. But when I explain the same thing to the general population or the general public, they need to understand that it is one of the rare disorders, but a serious complication, which is seen in a certain population of patients who have a genetic pattern or a genetic problem in them, which is seen when they are exposed to certain anesthetic medications. So it could be life threatening, but with the recent advances, with the availability of Dantrolene in certain high end tertiary setups, and with immediate and prompt management of the condition, the outcomes have been favorable in some of the cases.
So, what makes MH a time critical emergency? Now, how would you kind of explain this to the public? Now, you're talking to the patient relatives, you're talking to, say, example, you're giving a talk to a general public in a forum. Why is it so time critical?
we need to give some credit to the rarity of the disease when it comes to this, because it's not extremely easy for an anesthetist to make the diagnosis of malignant hyperthermia per se. So you need high index of suspicion when it comes to the diagnosis of malignant hyperthermia, because some of the symptoms which come across could be masked or could be difficult to assess in the initial stages. Having said that, early diagnosis is very important, and a delay in diagnosis could lead to rapid progression of the symptoms, which could lead to a mortality for about 70%. Early diagnosis and management could probably bring down the mortality, according to some studies, to even 5 to 30%. But when it comes to diagnosis, as Sir has already said, sudden increase in heart rate or tachycardia could be related to, a deficiency in the depth of anesthesia, and increasing the anesthetic could probably worsen the situation which already exists. So high index of suspicion could help in the diagnosis of malignant hyperthermia.
So, for people listening to this, we have a spectrum of anesthetists, from very senior experts and professionals to probably even postgraduates listening to this podcast. So, from your viewpoint, what are the earliest warning signs that people should look out for?
If succinylcholine is used, after the administration of succinylcholine, one of the important things that we need to look for is the presence of masseter spasm. There have been a lot of case reports where a patient who has been susceptible to malignant hyperthermia had isolated masseter spasms, which could gradually progress to generalized muscular rigidity. The other signs which should be alarming is sudden or unexplained increase in heart rate, unexplained or sudden increase in end tidal carbon dioxide. If there is increase in temperature, when I say heart rate, it could initially start with some amount of sinus tachycardia, which goes on increasing. Having considered the depth of anesthesia, having considered analgesics, having taken the adequate steps, there's still increase in tachycardia, which is persistent or could even remain in the higher end. For example, if it's somewhere around 160, 170, it's either increasing or still continuing to stay at the same level despite of the measures taken. Unexplained or uncontrolled sudden increase in EtCO2, which is disproportionate to the case, or even if it's a lab case, or even if it's with controlled ventilation, there is a disproportionate high increase in EtCO2. There is a sudden increase in temperature or hypothermia. Any temperature beyond 104 Fahrenheit should be considered as a pathological temperature, and we need to think about why the temperature is rising in these patients. And a diagnosis needs to be made keeping the complete picture in mind, as in it could be a probable case of malignant hyperthermia. So basically, the warning signs will be increased heart rate, sudden increase in EtCO2, temperature of more than 104, also some amount of hypoxia because of increased oxygen consumption. There could be a drop in saturation also. Muscle rigidity as such have been explained in few case scenarios where it has been seen as immediately as giving of succinylcholine, to some scenarios where muscle rigidity has only occurred after 30 to 90 minutes. Like sustained muscle rigidity has not been seen in some of the case scenarios even up to 90 minutes post administration of succinylcholine.
And you did mention a lot about the genetic predisposition to this condition. What's your take on genetic testing to understand MH susceptibility?
So when it comes to the gold standard for the diagnosis of malignant hyperthermia, so it is the caffeine halothane contracture test. But there are certain problems with it. That is, you need to take a muscle biopsy. It is an invasive test. Also, we don't have enough centers in India who are testing this. And even if we do, we need to send the muscle sample within 2 hours, and the testing needs to be done really fast for you to get a response to halothane or caffeine. So you cannot send the sample after a very long time, or it cannot be deceased sample where we have already lost the patient. So what other options do we have? So the other option we have is genetic testing. So genetic screening, when it comes to this, you just need to send 2 to 3 ml of blood, which is stored in EDTA. So it's basically a EDTA preserved sample which needs to be sent to centers. We have enough centers in India which are present in the metropolitan cities, may it be Bangalore, Chennai, Manipal, Hyderabad, Delhi, who have been doing the genetic screening tests. So there is no time frame when it comes to sending the samples. So you can send the sample even if you are suspecting a patient. Maybe the patient has a family history of any muscular dystrophies, or patient has a family history of someone who has had a complication, anesthetic complication, or a patient with a muscular dystrophy. If you're suspecting this patient could have a MH, you could probably go ahead and screen this patient with genetic testing, keeping in mind that the costing comes up to 40 to 60,000 depending on the centers where you are sending. And not just this, even in case of establishing a diagnosis, that is, if there has been a problem and you have lost the patient and you need to establish your diagnosis, as in, was it MH or not, for the interest of the family, which needs to be screened further, you can then again send a blood sample even afterwards, because we are just looking at the DNA to confirm the diagnosis of malignant hyperthermia susceptibility. Having said that, there have been more than 200 RYR1 receptors which have receptor mutation variants which have been documented, which could be susceptible to malignant hyperthermia. But all of these 200 variants are not pathogenic. So according to data which is available so far, we have only 35 variants of RYR1 and 2 variants of CAC-NA1S gene, which are pathogenic to cause malignant hyperthermia susceptibility. So the next question is, whom do we call as MH susceptible? So any patient who tests positive to any one of these 35 variants or one of the 2 variants of CAC-NA1S needs to be labeled as susceptible to MH. So by labeling them as susceptible, does that mean they will develop MH? No, it need not be, because it depends on, incomplete penetrance, variable expression. I'm not going into much details of the genetic model of that, like why they may not need to present with the MH. But definitely we need to label them as MH susceptible and take all the precautions that is necessary before providing anesthesia in these patients. Having said that, in the offset, we also need to know that a negative test does not rule out the possibility of having MH in these patients, because the final diagnosis can only be done by a contracture testing. Because negative testing, there could be still a genetic mutation which has not been, in the genetic panel which we are testing for, and could be positive, could be leading for malignant hyperthermia and has not been taken up by the test. So a negative test does not per se mean the patient does not have malignant hyperthermia, but a positive test should definitely be considered as a malignant hyperthermia susceptible patient.
Thank you, Shilpa. That was quite elaborate and quite in-depth into our understanding of what genetic testing is all about when it comes to MH. We will move on similar lines to Professor Rakesh Garg, our editor-in-chief, to ask him about what is the current state in India when it comes to the diagnosis and management. Could you just throw a little bit more of a bird's eye view of what's happening across the country?
Exactly. If you see the Indian medical health delivery system, it is expanding onto a very big platform. Now, India is becoming a medical hub with all type of surgical procedures with all complexities. And the total quantum of surgical output has increased to a manifold, and including, you can say, all organ systems and every type of procedures. So when we talk about in this context, the malignant hyperthermia, though it's a rare one, and it's a potentially, you can say, a fatal pharmacogenetic emergency as we were discussing. But if you see the whole quantum of the medical surgical output, it becomes a significant figure now. And regarding the management of malignant hyperthermia, since we are improving our knowledge, since we are improving our patient profile, since we are also taking up highly advanced cases, the quantum is increasing for malignant hyperthermia. And so same, we have to increase the diagnostic and management strategies, which has to be improved upon. Simultaneously, the good point is slowly, when the number of cases are being exposed, the people are getting aware of it. At least it was not labeled as now as unidentified sudden cardiac arrest or death in a perioperative period, labeling it as hyperthermia or a metabolic syndrome. So people are able to identify that probably it looks like malignant hyperthermia, and they are taking some action. So I think at this point of time, we have to provide infrastructure, awareness, and sensitization so that the current state of malignant hyperthermia into our country, we are able to manage the cases. And as Dr. Shilpa was rightly mentioning, we have little concerns about testing as caffeine halogen contracture test or ryanodine receptors analysis, muscle biopsy, the centers. But I think things are on an improving trend because of increased awareness. And as Dr. Balavenkat also mentioned, that the national societies, the professional bodies, including Indian Society of Anesthesiologists, are taking proactive action. So I think things are going in the right track, and the leaders from India, including Dr. Balavenkat, and we can say that all like-minded leadership is also required in addition to the best clinical management to improve our outcome of malignant hyperthermia.
You did bring a very important topic here for discussion, that is, how does somebody diagnose that they have had a case of malignant hyperthermia? Now, Shilpa did mention that you need some amount of lab testing to confirm whether it could be the contracture test or it could be the genetic screening. But is there any clinical grading that people can follow, wherein they can say, yes, I had this case, and because of this grading scale, just like our GCS, we have scored these many points, and therefore I think it's MH.
I agree fully that Dr. Shilpa also mentioned, and we are very sure that certain tests, for example, the caffeine contracture test and the receptor analysis, they have a very high sensitivity, almost 90 to 100%. So we have to get these tests to confirm that this is malignant hyperthermia, because it has a specific management and patients are salvageable. But simultaneously, we also need to understand that the genetic testing is limited by many factors: the cost factor, the logistics, the availability of labs, and the person who can do this testing on time. They are time-limited testings, and they have to be done on time, along with the transport of samples to these labs where they can do it. So what we are left is we have to manage the patient, and then comes the, you can say, the second ladder of diagnosis, which always remain the clinical one. And we can always say that it's like a screening tool, and have been certain screening tool which has been mentioned in the literature, and clinical grading scale is one of them. And if you see the clinical features that we were discussing, Dr. Balavenkat and Dr. Shilpa were mentioning about them. If you saw those clinical features, they are very specific to malignant hyperthermia. I think into my clinical career, or as per the literature we study, the combination of these clinical features is more indicative of malignant hyperthermia than we can think of any other disease, whether it is hyperthermic response, septic response, or it is any other hypermetabolic response. We do not see these type of sudden increase in the parameters. Say, for example, the temperature increase, whatever the infective episodes are there, we will not find temperature increasing by a degree in minutes, and it will reach 100, 400, 500, 6. And sepsis usually say 100, 200, 3 is okay. Same is with the capnograph. If you see that the end-tidal started suddenly increases, when you know that the lungs are okay, the ventilatory parameters are okay, the baseline was okay, but a trigger agent, which you know now that these are the trigger agents, if I use those combination of volatile anesthetics or drugs like scoline, and if they suddenly increase, it's a very good clinical indicator, yes, that's something in going in the direction of malignant hyperthermia. And similarly, if you see through this grading scale, the presence of respiratory acidosis, the cardiac changes that they happen, they will throw tachycardia, sinus tachycardias, turning into ventricular tachycardias, and at times ventricular fibrillation also. They will have very rigid signs of muscle rigidity. We don't have many other disease condition or drug-induced complications when there we have generalized muscle rigidity. We understand fentanyl will give some amount of rigidity in higher dosages, but in routine practice, we'll not be using 3 mics, 4 mics, or 5 mics kg of fentanyl, and we don't expect they will cause muscle rigidity. So again, an indicator of it. And in addition to it, if you see the response, the muscle response that happens, the rhabdomyolysis that happens, you will find that the urine color starts changing very rapidly, in sometime in hours. So this combination of clinical grading scale is very, very collaborative of a diagnosis. And they have labeled it, they have given certain points, 15 for each usually. If anything is going beyond 60 plus points, it's more confirmatory. And if now, since we are getting cases which will be done in the family now, this family history again is a very strong indicator. And once we have somebody a history of malignant hyperthermia or malignant hyperthermia like presentation, we should have a suspicion of the family history strongly positive, even though we may not be having genetic analysis of the whole family, but we will keep them as a sensitive patient to malignant hyperthermia. And this clinical grading will help us to identify early. And obviously, the early management and the drug management remains the keystone.
Thank you. When it comes to the practice of anesthesia in our country, the anesthetists do face a lot of challenges when it comes to equipment, the monitoring standards that they can maintain, especially in the peripheries. Do you think this is a very big challenge when it comes to diagnosing MH and managing, of course? Now I'm talking about tier 2, tier 3 cities and even a little bit remote areas as well. How does somebody working in such places who's listening to this podcast, how does they diagnose and manage MH?
I understand. I mean, when we say the clinical diagnosis, why not to have something into our pre-anesthetic checkup itself, which is indicative of it? We usually talk about any history of anaphylaxis, any history of sudden changes which requires some specific medical management in perioperative period. So this has to be a part of it. And how can this be a part of it? We have to create awareness. Now, if you see medical science, though we usually say that the common diagnoses are the commonest one.
Yeah.
So if I get a patient and if he gets hyperthermia, the commonest will be the sepsis probably. So this means sometimes we will try to keep the malignant hyperthermia as a diagnostic feature 3 or 4 or 5th. But once we start creating awareness that I have used choline, I have used halothane, I have used sevoflurane, isoferrin for this drug, this patient probably have these combination of features. So I think this lack of awareness has to be turned into more sensitization and then training of its management, because early diagnosis is the key. We cannot wait for long hours. It will not give a long time. And then comes the diagnostic features. I understand that the genetic assessment, the muscle biopsy testing requires a huge infrastructure. It incurs a lot of cost. And seeing for the rarity of disease, we need to also to understand the commercial aspect of it. We cannot have labs at all nook and corners of the country. So somewhere we have to have collaborative efforts through some organizational support system so that they can be sampled and report given at the earliest. And once we get it, probably we will start. We have sensitization, we have diagnostic facilities, and then once comes the next is, people will ask, why should I open a lab? There are not many number of cases. But what if I have a registry and people start reporting it? And I know that this is the demographic and geographical area, which is a high risk area. We can identify, we don't have data from India. Dr. Balavenkat has very rightly mentioned about it. We need registry. And if I say that this area is more prone for MH, maybe because of genetic variation, genetic mutation in that geographical area, or demographic profile of that particular patient, why not to have more infrastructure labs and definitely the availability of drugs, which will make both the things available, the early diagnosis and the management. And simultaneously, I think it's the right time, the various accreditation agencies should start thinking of, when they have a checklist, they say there should be code blue, there should be an emergency thing. Why don't we have something which includes these type of rare emergencies? I am aware that we have rare disease conglomeration, rare disease groups, which is held by various professional organizations. I think this should also become a part of it, so that we have safety protocols, we have sensitization training programs, we have support from the infrastructure, diagnostics, and the drug availability. We have the registry. I think it will not be challenged then. But till then, we have to work a little bit into this context. And I'm sure that the leadership of ISA is looking into this. A like-minded person has to come up so that we can make those challenges into ease of providing care to these patients as we used for other complicated surgical procedures.
Thank you, Dr. Rakesh. Very well way of putting the entire picture into a perspective here. We would like to move now to Dr. Nandini, who's had the experience of managing a patient in MH crisis. So, welcome to the episode, Dr. Nandini. Thanks for joining us. Could you share your experience of this case with all our listeners as to what happened and how did you go about managing it?
Thank you, Dr. Murali. It's a privilege to be in this podcast. I had a patient recently, about 2 weeks back. This was a 10-year-old boy who was being operated for scoliosis surgery elsewhere in the hospital. And the plan there was endotracheal intubation with lines and so on. So what happened was they induced the child with propofol and succinylcholine. Mind you, this child did not have any previous history of anesthesia or any incident in the family. So they intubated the child under scoline, and then they maintained the child on oxygen and air and sevoflurane. And it was a couple of hours into the surgery that they started noticing tachycardia. So initially, again, a confound. They thought it was light anesthesia. They gave analgesics. It didn't settle. And then the CO2s were climbing. That's when hypotension started. And then standard treatment, again, there was no impact. They started noradrenaline. Then it became an arrhythmia. So they diagnosed it as SVT. And then they realized that there is some problem. The temperature was also slowly climbing. So then they alerted the surgeon, and then the child was made supine. Cardioversion, standard treatment for SVT was instituted, support, noradrenaline infusion. And then they closed the incision, and then they decided that it has to be moved to a higher center. So that is how the child came to us at SRCC Children's, and the child came to our ICU. So when the child came in, he was hypotensive despite vasopressors. We did an echo. The EF was about 10 to 15%. We stabilized the child with amiodarone infusion. Noradrenaline was on. The core temperature was about 39 degrees. The labs, the pH on admission was about 7.1. The potassium was 6. So GI infusion and measures for managing the hyperkalemia was started. And the attempt was made to be, stabilizing the child. It was a couple of hours after admission that we were contacted, because at that point also nobody had really started thinking about MH. This is to just throw light on the situation that MH again is not a diagnosis which comes first to mind. So we were called in, and then the ICU team asked me, what do you think this is? So I was just going by all the parameters. So looking at, say, the anesthesia chart, scoline was administered, sevoflurane was administered, and while we didn't have a concrete, any proof as such, we just said, okay, this could be MH because it was a neuromuscular scoliosis. And looking at the whole picture, I said, okay, let's give Dantrolene. Of course, there was hyperthermia, there was hypercarbia. Hypercarbia had come down to a significant degree because they were hyperventilating the patient. But when I saw the patient, he was hypothermic, he was tachycardic. And the labs were also, he was needing supports. So I said, let's give Dantrolene. So that's when we administered Dantrolene in a dose of 2.5 milligram per kg. This child was weighing about 20 kg. So we needed 3 vials at that point of time. So we had the 20 milligram per vial of Dantrium, and we administered Dantrolene. core cooling was also instituted simultaneously. And so it was the first time I was actually administering Dantroline, and we really didn't know how the patient would respond. But dramatically, within about 10 to 15 minutes of the Dantroline, the heart rate came down from about 180 to about 110, and the BP started stabilizing. So that's how we kind of, you know, realized that the drug is working. It was almost like magic. The inotropic requirement came down because the BP shot up. He was on high dose of inotropes, 2 inotropes at that point of time. And then within about 20-30 minutes, the requirement of the inotropes came down. So then we decided to continue the Dantroline in the prescribed dose of 1 milligram per kg every 6 hourly. And it took about 48 hours for the child to eventually get stabilized and extubated. So this was a case.
Thank you for sharing. What it highlights is one is the atypical presentation. Now, in the last 40 minutes, we've been discussing how malignant hyperthermia can come like a bolt from the completely unknown that people might get hit. But the case that you highlighted was how atypical the presentation was, and how the patient actually landed in your ICU without anybody even thinking about MH. Because I think during that time the entire thinking would have been something cardiac because there was arrhythmias happening and EF was low. But you thought about giving Dantroline and it made a huge difference. Was it easy to procure Dantroline for you?
So we are lucky that at our hospital we have a stock of Dantrolene, and this came about because for years I've been thinking we get a lot of children with myopathies. I've had patients coming with a diagnosed myopathy and RYR. They'll come with a genetic report that there is an RYR mutation, and I've had to tell in the past that there is a possibility, a susceptibility, but I don't have Dantrolene. So this was kind of a sort of a personal crusade, if I may say so, over the last 6 years, and we were lucky that we had a donor and we could procure Dantroline. It took quite a bit of effort, but since the last 2 years, we have been stocking Dantroline, so to speak. It just makes us more prepared in an eventuality. And I always tell my parents that it's okay if you have come with a diagnosis. I know that there is a susceptibility, but the large majority of our patients don't come with genetic testing. And those are the patients which I'm more worried about, because as a standard, we would still not use trigger-free anesthesia for all our patients. So we would still go by the standard anesthetic, although we don't use choline so much. But sevoflurane is our go-to anesthetic for most cases. So yes, we had Dantroline, and that really saved the day.
So another question here is, you're from Mumbai. I mean to say, I don't know how many surgeries take place in Mumbai every day, but it is definitely in not even thousands, tens of thousands. Are all the centers which stock Dantroline available for others to kind of, procure from? Or is the knowledge there that, if I have an issue that Dr. Nandini has got Dantroline?
Yes, so ever since we stocked it, actually, I've got multiple requests from Pune, from Mumbai, other centers that, okay, we have this patient. In fact, we had given out our Dantroline vials to a center in Mumbai, and that patient was actually, they used it, and the patient did well later on. So, yes, we have announced that we have Dantroline, and we are okay to give out our vials in case there is a crisis, yes.
Okay. Now, my question to Dr. Shilpa or Dr. Bala or Dr. Rakesh is, what is the strategy if Dantroline wasn't available in this patient? Dr. Rakesh, would you like to take this question?
If you see the management point of view, the drug of choice always remains Dantrolene. Once the diagnosis is confirmed, you can say it's almost like not exactly antidote, but it's like an antidote basically. So you have to give it. Now, we should try arranging it as soon as possible, because though it should be given as early as possible, but sometime it may not be accessible, so we need to procure it as soon as possible. And next comes the the supportive management or the organ support management. Now, this patient will have cardiac issues. This patient will have a very high risk of renal failure, acute kidney injuries. These patients will have. They will have a lot of electrolyte imbalances in these patients, and they will be mounted on with the acute hyperthermia. And if we talk about the metabolic change in the form of acidosis and all those things, there will be a combination of these effects. Now, when we try to say the management, it has to be multi-organ support. For respiratory support, yes, we'll go ahead and do it. For hydration, we'll go ahead and do it. For hypothermia, we'll start our conservative measures. For kidney support, we may require some kidney support system. But having said that, an acute event of malignant hyperthermia, a full-blown multi-organ involvement, has very high mortality. In spite of doing all those things, sometimes patient may not give us sufficient time without drug to sustain for a longer duration. So this is what we need to start the supportive management, but simultaneously we have to procure the drug and it has to be given timely, and that is what's the most important aspect. We need to look at how logistically we can make arrangement of the dantrolene to these patients at the earliest in case some eventuality happens.
Thank you. I think in the last 45 minutes, we have explored the present issue that we have in our country when it comes to malignant hyperthermia. We've understood a little bit about how the clinical picture manifests, what are the diagnostic modalities we have, and how to go about if we do face a problem. My question to Dr. Balavenkat here as the ISA President National, what immediate steps can Indian hospitals take to improve their preparedness for malignant hyperthermia?
So I think first I consider this as a very, very important podcast. Common things are common, but rare things which are fatal have also to become common in our thought process. I think this podcast is an effect towards that. Every single life that is lost is a loss forever for that family. So we cannot consider anything saying that, oh, it's a rare disease, so I'm not prepared to handle it. I think this is against human thinking, not ethical. And I personally feel that Dantrolene sodium, current form that is available 20 milligram, as I said, 22,000 rupees, 6 vials if every institution stocks, that's about 1.35 lakhs. And with a shelf life of 2 years, it comes to roughly 65 to 70,000 rupees per year. And if you break it down, it's about 5,000 rupees investment per month. So now we need to ask a question, is an institution not capable of offering 5,000 rupees per month to prevent a possible mishap that could happen and preserve a life? Is a question which we need to ask and introspect ourselves. And on my personal level, we are stocking Dantrolene in my institution since 2018 after a lesson that we learned where we lost a patient on the table. And since then, we have kept a stock of it and we could save 2 lives after that. So it means the joy of preserving life should become the utmost importance for every single institution. And for that, it's important to invest. What we are also trying to do is to make it freely available in this country. We have taken steps to make Dantrolene to be manufactured in this country. We have done a survey and we want to take this forward. We wanted to get concurrence from at least 250 hospitals in this country. If they agree to buy, I think in 1 year time, we will be self-sufficient. We need not look for imports. We can have our own manufacturing units manufacture. India is so proud of its capabilities, which we have seen in multiple times of challenges, including COVID, when we came out with COVID vaccine. Similarly, we have the inherent potential to manufacture and there is no need to import. So we are moving in that direction. So first one is to convince people to stock Dantrolene, convince people to buy Dantrolene, convince every single hospital management to invest 5,000 rupees per month in an endeavor to preserve life. And I am very, very confident that this podcast will provide the necessary stimulus for all those who listen to it, including the anesthesiologist, who would then apprise their hospital management on the importance of procuring Dantrolene. And possibly post-podcast, the Indian Society of Anesthesiologists will conduct yet another survey, find out all those who are keen to procure it, and we will make sure that initially we will do a collective placement of an order and import the drug, and later to produce it permanently in this country with a single notion of preserving every single life which comes to the intraoperative surgical procedure. One more point I just wanted to add for all the anesthesiologists who are listening to this podcast, based upon the current literature, it is very, very common in patients with musculoskeletal disorders, and it has also been noticed that it's very, very high in the state of Kerala. The first 5 reported cases were all from Kerala. So a note of caution, as it runs in family, as there is a genetic preponderance, any patient they see from Kerala, any patient they see with musculoskeletal disorder, immediately it should strike to them there is a possibility of malignant hyperthermia. If they have Dantroline, well and good. If not, try to avoid the trigger agents and go for a total intravenous anesthesia. And in case if they have to use inhalational, to make sure that they take off the trigger immediately. So these are my messages, and I really thank the IJA leadership for taking up this podcast, and I'm 100% sure that this podcast will result in preserving several lives and create the much needed awareness in this country.
Thank you very much, sir. At this point, on behalf of the IJA podcast team, I would like to thank you as the ISA president, and also Dr. Bajwa, the ISA Secretary National, and the entire General Council team for taking such wonderful measures, I would say, towards patient safety and improving the lives of all the 140, 130 crore people of India, and also making the working conditions for anesthetists better day by day. Thank you very much on behalf of the IJA podcast team. Thank you.
Thank you.
So
Thank
I
you
would
so
just like
much.
to, I'd like to wind up this podcast with one question to Dr. Rakesh. He did mention earlier in the conversation about registry that we don't have a registry in India. Are there any thoughts regarding this from your end, Dr. Rakesh?
I think we need to think of, and probably in case I can transfer this question to Dr. Balavenkat, and I will add on this question again to him that taking the leadership of not only of ISA and WFSA, both the big bodies have taken many concrete steps. I would request Dr. Balavenkat Subramanian to guide us that how can we take this registry forward, because the national leadership will make it more robust and more reliable. This is one. Second, I will also request Dr. Balavenkat sir here to give us some guidance as common anesthesiologist, because the leadership has taken a step in various aspects. They are providing a role for sensitization, this podcast. The leadership has taken a role for manufacturing, Make in India program, make its availability. Dr. Balavenkat, what do you suggest to us as common anesthesiologists? How can we contribute so that these type of rarity, disease, mortality does not happen? So what are your suggestions to us? And what do you think about the registry programs?
I think it is always said the child, when it cries, gets it from its parent what it needs. I think the most important thing that each anesthesiologist have to do is to create an awareness and sensitize the administration, the hospital administration, to procure it. And I think since it is available in this world, and it is not uncommon to have this disorder, every single anesthesiologist have to convince their hospital administration to procure Dantrolene sodium. And as I said, we will try our best to start the manufacturing in this country and probably reduce the cost that would be incurred by the hospital administration. But until then, since we have several cases being reported from several parts of this country, And also when I shared it in my groups since 2018 that I'm stocking Dantrolene with me, there have been several calls for me from several parts of this country asking for Dantrolene. So it clearly indicates that it's not an uncommon disorder. It clearly indicates that there has been significant morbidity and mortality because of this. And most of the times it has been ASA grade 1 patients who would otherwise have lived for decades after this particular surgical procedure. I just also want to quote that there was a doctor couple child who lost their life on table for a simple procedure like tonsillectomy in one of the big cities of this country, again to MH. So taking all this into consideration, I would sincerely request each individual anesthesiologist practicing in this country to take this as a task to speak to their management, and please do get back to us. If you give us the indent, we will make sure we procure it and give it to you. This is to start with. This is the first option. And as I mentioned, the second option would be to manufacture, and third option and option which was suggested is to have a registry to collate all the data that is arising out of it, which is extremely crucial as we move forward.
And I'm sure, as rightly sir said, the Indian Journal of Anesthesia, the academic phase of the ISA, will always be ready to have the views and reporting so that we can take a registry and we can have something which is in-house. You can say the data collection, the information, the demography, and hopefully the type of receptors, the variants we have. So I will urge at this junction that those whosoever have the facilities of it, they can always come up and say that these variants are more common, these type of manifestations are more common, these are the earliest features. So try to collect those data on individual basis also, so that we can collate sometime later, and IJ will be more than happy to share this information in the interest of country as a whole.
Thank you.
So much, Dr. Rakesh and Dr. Murali, for hosting this very informative, very impactful, very enriching podcast. And on behalf of Indian Society of Anesthesiology, I thank the IJA podcast team, and I thank our special guests today, Dr. Shilpa Bhat and Dr. Nandini Dave, for sharing their important insights. And I'm sure a podcast like this will preserve several lives. And this is the alternative of not having Dantrolene, is to create awareness. Thank you.
Thank you, sir. Thanks a lot. So, as we conclude this very valuable session on malignant hyperthermia, it's been close to 55 minutes that we've been discussing. I want to thank all our expert panelists, Dr. Balavenkat, Dr. Rakesh, Dr. Nandini, and Dr. Shilpa, for sharing their insights and experiences. The knowledge that we exchanged today, from the diagnostic approaches using clinical scales to management strategies in resource-limited settings, this will undoubtedly enhance our preparedness for this rare but critical condition. Please remember, awareness and readiness are our best defenses against this condition, which is malignant hyperthermia. And I would like to thank all of you for sharing your time with us and participating in this podcast. So let's continue this important conversation in our respective institutions, as Dr. Balavenkat mentioned, with the management, and let's improve lives and save more lives. So till our next episode of our IJA podcast, as we always say, stay safe and stay curious. Thank you.